Well, I guess it's time to confess, I know nothing about mitochondria, but it's too late to find a replacement right now, so you guys are stuck with me for the next little while. But thank you so much for having me, and it's such an honor to be part of truly a revolution. That's a word that I think is very apt for what your team has been doing, and I'm just very, very fortunate to have the opportunity to play a tiny role in it. So disclaimer, and this is an important one, I am not a biologist, I am a physicist. So that slide that Ori showed, I'm going to spend the rest of the slides to actually show you how we got there. But I'll begin with a little bit. I also, for those of you that know me, I like history a lot. And I'm going to begin with mythology, actually, because it is quite related to something that I've dedicated my entire adult and academic life to. So you probably have heard of Zeus, and it's a nice and sunny day in Toronto today. So hopefully Zeus doesn't show up. But it took me about 18 years of my life to realize that we do have a real human person equivalent of it. His name was Alexander Graham Bell, and he was very famous for the discovery of this device that you might have heard of called the telephone, right? But his proudest invention, and I actually had to look this up because it is literally documented, is the discovery of the photoacoustic effect, okay, where light makes sound. And the parallels that I draw between Zeus and Alexander Graham Bell, who gave us photoacoustics, is this idea of lightning and thunder, right? First, you actually see the lightning, and sometime later, depending on how far you are, you will hear the thunder, right? We've all experienced that, and hopefully we haven't been too close to it, but the idea is that sound travels, and we're able to hear it. So what does this have to do with photoacoustics? Well, it works in a very, very similar manner. The only difference is, of course, we're not shooting lightning towards our biological tissues, but we have these laser sources, which when absorbed into tissue, they will undergo a thermoelastic expansion. And this thermoelastic expansion is going to give rise to an acoustic wave, which we then detect with an ultrasound transducer. And virtually everything that we know about how ultrasound imaging works, and we know quite a lot about it, is actually implemented in photoacoustic imaging. So now, from this sort of very simple physics effect, right, it turns out you can do a lot with it. But every time I talk about photoacoustic imaging, the first question that people ask is the right one as well. We have optical imaging. We've had it for quite literally hundreds of years now, and virtually every major discovery in science, in my opinion, has sort of had one of these very beautiful images that usually end up in the cover of journals, right? And now this is where we have to talk a little bit about scattering. So optical-based imaging techniques, such as two-photon microscopy, confocal microscopy, which really are ubiquitous to virtually any scientific discovery, they rely on the detection of photons. You send in photons into tissue, and what do you get back are photons. Photoacoustic imaging works a little bit differently. You're sending photons into tissues, but what you're getting back are sound waves. And these sound waves, because they are capable of traveling much, much farther away into tissue, allow you to now achieve the same sort of resolution as you do with optical imaging, but in clinically relevant depths. We're now going from a few hundred microns to centimeters into tissue. And the reason for that, and this is where the physics comes in, is because optical scattering is orders of magnitude higher than acoustic scattering. And it's as simple as that. And people have quite literally revolutionized this field, although nothing much happened from Bell's initial discovery in 1880. In the 70s, there was some work with hemoglobin, right? But the first ever documented, at least, maybe somebody did generate it and they never published it, but the first ever photoacoustic image was actually done in the mid-90s. And from the early 2000s, right, which is when I first heard about this field, the field quite literally exploded. We now have our flagship journal called Photoacoustics. That was an easy one to name. And this has now become one of the highest impact journals in biomedical optics, which is quite telling. And as not always, but as per usual, there's a cohort of commercialization activities that follow major discoveries, and photoacoustics is no different from that. So now, why photoacoustics works and why is it so versatile is because you can deliver the light into biological tissues in many different ways. And this slide, I could probably spend the rest of my time just talking about it, but I won't, just to give you a glimpse of how you can actually do photoacoustic imaging. And this allows you to now extend your spatial resolution, your penetration depth from single cells all the way to entire organs. And this is the only medical imaging device or medical imaging technology that permits you the ability to do that, which is quite exciting because it has quite literally revolutionized biomedical imaging. And the beauty of photoacoustic imaging kind of is derived from Mother Nature in many ways is because a lot of very interesting molecules that are metabolically interesting also have very unique optical absorption. We as humans had absolutely nothing to do with this. This was entirely just given to us by Mother Nature. All we realized is that because we have this unique optical absorption, we can do some very simple mathematics, which I'm not going to go into, for you to obtain now these beautiful high-resolution images of structure and function at the same time. And this over here is a vasculature image that also shows how much oxygenation there is within the tissue. And it kind of looks like an anatomy textbook, but it's a real acquisition. Now, I came up with a word, and probably the only one I'll ever come up with, called verscalability, and that probably describes photoacoustic imaging very well, because as I mentioned, you can go down to single cell resolution. For those of you, especially the grad students in the audience, that do H&E histology, right? It takes forever to actually generate these images. Well, it turns out you can do that with photoacoustic imaging to be able to detect the presence of DNA and RNA. They, again, absorb a lot of light. If you're interested in small animal models, right, that video up there was supposed to play on the top, but that's okay. What you will actually see is the ability to, thank you for that, maybe not. Right there, you got it. That's okay, if it doesn't play, no worries, I'll explain it. So the idea here is that you have a single red blood cell that is actually flowing through the vasculature of a mouse's brain. And what you see there, and it's kind of captured on the picture on the left of that image, is as the single red blood cell is moving half a second in time over about 50 microns in space, it is losing its oxygenation from about 40 to about 15%. This is metabolism in action, right? This is physiology 101, but these are some early demonstrations of photoacoustic imaging to show his versatility. Now, I happen to work at St. Michael's Hospital, right? So I'm very interested in clinical translation, and I'm very sort of encouraged to see some of the reports that have come out in the literature that now demonstrate the immense clinical capabilities of photoacoustic imaging. So that is the image of brain vasculature, right, in comparison to the 7 Tesla MRI. And if I was to tell you the cost of photoacoustic imaging compared to 7 Tesla, most CFIs would probably look very different when they put requests for these equipment. So with that in mind, I just want to maybe talk a little bit about some of my work, right? And I call this a tale of 2 organs because I was very fortunate enough when I was recruited at St. Michael's Hospital to work with Dr. Darren Yu, a nephrologist, to introduce me to this fascinating clinical problem that I had no idea it even existed, which is assessing the quality of kidney transplants. So this is a mitochondria-less story, but you'll probably realize that a lot of those elements are actually quite applicable to the work that we've been talking about here. And the second part, and again, this is, I was just remarking to somebody right before I came up here, I'm very fortunate to have been invited into this revolution and very fortunate to work with many very talented clinician scientists that see the potential of these techniques. So I'm going to give you a bit of a glimpse of some of our work there with, again, photoacoustic imaging being sort of the binoculars that we use to look at tissue in a non-destructive, non-invasive, multiple length scale manner, and hopefully one day to demonstrate clinical translatability. So I'll begin with the first story, right? And this is, I almost feel embarrassed after 3 clinicians came up here and talked to us about very important clinical questions, but my understanding of the 3 very simplistic ways of determining the outcome of a kidney transplant, one has to do with the quality of the incoming kidney, right? That seems like a very simple one. Of course, ischemic reperfusion injury does occur in kidneys as other organs, right? Where once the organ is ischemic and reperfused again, there's a lot of very well understood injuries that do occur there. And the third part of it, which I won't touch on it today, but we're doing quite a bit of work, there's a lot of post-transplant sort of compliance. Sometimes it's just pure luck, right, for these patients to have good outcomes. But specifically, I'm going to be touching on number 1 and 2. And this is our trial. The design of the trial was actually quite simple. Once the kidneys came in at St. Michael's Hospital, we imaged them on the back table, right? They're still sitting on ice, but after having heard the talk from before, maybe we should reconsider that. And ultimately, once the kidney has been imaged on the back table, we sort of push it back to the urologist, right, who actually reperfuse these kidneys. And eventually, if the patient consents, we do a secondary scan. And this probe over here is basically a handheld photoacoustic probe that my very talented residents with their steady hands just hold in a sterile manner. And we did this, I believe we ended up with about 60 patients, right? We recently published an early report of this, and we're continuing to follow them up as well. So I'm going to take a bit of a deviation here because, and the story of why this happens is almost irrelevant, but we also realize that there's a lot of information that's coming to us from the ultrasound images, which we acquire at the same time. As I mentioned, photoacoustic and ultrasound imaging are using the same hardware, right? So we discovered a technique that can identify the degree of fibrosis that is occurring within these kidneys. So once these kidneys are sitting on the back table, we developed a mathematical technique that can now estimate the degree of fibrosis. And when that correlates to the histology, right, the little tiny sample that they take histologically, the correlation across all of our patients is actually not too bad. And then we followed these patients for about a year, right? So dividing them into living and deceased donors, not surprisingly, living donors do slightly better in terms of their eGFR a year later after their transplant than deceased donors, although we weren't actually powered to demonstrate that, but the signal does appear. Now, what's kind of interesting here is that if we now rely on that tiny little biopsy, which is less than 1% of the kidney volume, what you actually see is you don't see any relationship with eGFR afterwards. But if you now do a three-dimensional scan of the entire kidney volume, not surprisingly, you're sampling a lot more of this kidney than that tiny little biopsy. And you see this sort of staircase that is actually demonstrating to us that our imaging technique is carrying information about the functional outcomes of these kidneys. And it begins with structure, right? And the structure in this case was the fibrosis. Now, back to the photoacoustic imaging and the ischemia reperfusion injury. As I mentioned, we have the ability to look at multiple different wavelengths at the same time. And living and deceased donors, before and after perfusion, changed their optical absorption of the kidney because oxyhemoglobin just came into that kidney. But we have the ability to also measure their oxygen saturation, right? And when you look at how these patients compare pre and post-transplant, you start to realize that total hemoglobin as well as their SO2 increases, but there's a large variation into that increase. And why that occurs is because when you now look at how the oxygen saturation of the kidney is changing as a function of perfusion, which is measured by the hemoglobin, you start to realize that there's significant differences in slopes between the way that a deceased donor kidney is perfused compared to a living donor, and even the way that these kidneys are being reoxygenated actually changes significantly between living and deceased donors. And now we're actually looking into comparing and going back to see how these kidneys did in the short term for delayed graft function. So this sort of demonstrates the potential of photoacoustic imaging in a clinical setting, right? It's a very simple measurement that doesn't take a lot of time, and the surgeons have been very, very welcoming. I did still this for Maury, and I'm going to go through it very, very fast, right? But ultimately, I don't think I need to give much of an overview here, but ischemic reperfusion injury in the context of the liver, it was the other application of photoacoustic imaging. So very fortunate to work with Ori as well as Dr. Marcus Seltzner here at UHN and his lab. So the experiment was actually quite simple, and I'll just briefly go through it. So it was the skeletal muscle mitochondrial isolation, which ultimately meant that we can now go back and image these kidneys, the livers in situ, right? And this is what the setup actually looks like when the left lobe became ischemic, whereas the right lobe remained normal, and that served as our control. And of course, biopsies were done at multiple time points. But now I'll actually show you the photoacoustic sort of imaging aspect of this, right? This is some of the pictures, and these pigs were actually followed up to 24 hours post-intervention, so to speak. So from a photoacoustic perspective, right, we were imaging at various time points here, right, in the before and after the introduction of the mitochondria. And again, because Zori did a great job with this, I'll just again highlight the observation that we saw here, which was very, very strong, right? Once you introduce the mitochondria into the liver that has been injured, you have the ability to demonstrate that in comparison to its right lobe control, right, the oxygenation actually improves compared to baseline, whereas that does not occur within our control. So this is a very interesting observation, right, that demonstrated again the ability of photoacoustic imaging to be used as a real-time sensing tool. However, this section is called mitochondrial tagging, so for the next few minutes, I will talk to you a little bit about the potential of exogenous contrast agents. Everything that I told you about up until now relied on changes in perfusion, hemoglobin, and there's some other markers that you can detect, but photoacoustic imaging as a field has quite literally revolutionized the way that we think about contrast agents in the context of their ability to be triggered either through some microenvironmental trigger or some kind of an external trigger, right? Whether it is temperature, pH, some kind of an enzymatic activity. And an example that I'll show here is, again, much like Mother Nature gave us very unique absorption of oxy and deoxyhemoglobin and other endogenous sources, you can also, now with very clever sort of chemical engineering, you can now design probes that meet your specific requirements. And this is an example of, it is related to mitochondria, but not quite what we're talking about here in this, in the context of transplantation, but the idea is that if you have this carboplatin cyanine molecule that becomes your source of contrast agent, you have the ability to have them accumulate into the mitochondria when you actually fire a little bit of focus ultrasound into the mitochondria. And what's very interesting about this is that photoacoustic imaging has far higher resolution than your good old standard fluorescent images, where you see basically just a very blob of signal lighting up in the tumor, but you can actually see with photoacoustic imaging shown in the image on the left how that looks like in the context of its accumulation over tumor. And because photoacoustic imaging is not just a sensing, but rather a three-dimensional imaging tool, you have the ability to now do and perform three-dimensional imaging to track over time the accumulation of your endogenous contrast agents. And to my knowledge, there hasn't been any mitochondrial contrast agents, so I very much look forward to the second talk, right, to see whether or not we can actually now develop these photoacoustic tags that are achieving the goal of us being able to track the location of mitochondria in vivo over depth in clinically relevant scenarios. So with that, I'm going to conclude. And hopefully I've convinced you that photoacoustic imaging is a non-invasive modality that can probe across multiple biological length scales. It can simultaneously detect the impact of the mitochondrial transplants on organ anatomy and physiology. And my hope, and I'm probably going to dedicate a good chunk of my research program to this, is to try and develop these exogenous contrast agents that can now visualize where these mitochondria are going as a function of time in a non-invasive manner. And that to me is perhaps the perfect combination of all the wealth of biology and chemistry that you guys sort of contribute to, along with a tool that can be very useful for the monitoring. So with that, I'll just thank my lab, and specifically Alex Chen, my grad student, who spearheaded a lot of these mitochondrial studies, and of course the collaborators. And thank you again for bringing me here and inviting me into your midst. And I very much appreciate this, and thank you.